Again, please go back and memorize what muscles are there in each group which carry out this movement, and the nerve roots which innervate them. Alright? So to assess for flexion, ask the patient to lift his leg straight up, and then you press down here. Encik, tolong angkat kaki. Okay. Sekarang, that's how you assess extension. You try and pull in this direction, and the patient pushes down. Sometimes to make it easy, you can just tell the patient, okay, whatever it is that I'm going to do, saya tolak ke saya tarik, lawan saya. That's the easiest. So for abduction, encik, saya cuba tarik kaki ke masuk, encik cuba tolak saya. Then you place your hands here. Patient resistance. Okay. For adduction, it's the opposite. In that manner. Some put their hands like this, but I think that one is not. Whether it's like this or whether you grasp the leg, it's not of great importance. Importance is you know what muscles you are testing. So at the knee joint, we want to assess flexion and extension. So, encik boleh tak tolong letak tapak kaki flat atas lantai. For extension, you pull, patient resist. So, opposite, extension, and then the same for the other leg. Remember, you assess both extremities and only link for one side. Lastly, for the foot, you want to assess palmar flexion and dorsiflexion. So dorsiflexion first. Encik, saya tekan tapak kaki, encik cuba lawan. Okay. Sekarang encik cuba pijak.
Tekan back.
Okay. I'm not that fond of the motor examination because I'm not that strong. The patient's always stronger than me. And last thing you want to assess in the foot will be eversion and inversion. So anyone tell me what is the difference between these two movements?
Inversion means your sole of the foot point inward. Eversion means your sole of the foot point outwards.
Yeah. So you have to grip the foot of the patient, and then you tell the patient, I am going to twist your foot. If I tell the patient, I'm going to twist your foot outside, and you try and resist me. What movement are we assessing?
Can you repeat it?
I'm telling the patient, I'm going to twist your foot outward. You must try and resist me. Inversion. So, I think cuba lawan. Okay. So if you want to test for inversion, it's the opposite lah. You try and twist the foot inwards, and the patient resists. Okay. Good. And again, we do the same for the other side. And then reflexes of the lower extremities. What reflexes do we want to test? Knee and Achilles. Okay. So for the knee jerk, this will be the position. And it's very abdominal, especially if you're not strong enough to lift the whole leg of the patient. So palpate the tendon. And then okay, put your fingers together and pull when I strike. Okay, 1, 2, 3. Okay, and then for to assess the Achilles, the tendon reflex, the leg must be in such a position, slightly flexed and externally rotated, foot upwards, and then you strike at the tendon. Okay, and then at this point, you also want to test Babinski's reflex. Okay, Okay, this one I'll just demonstrate how to do it. You should use this, or you can use a pen, a key, whatever that you have, and then you run it along the lateral side of the foot and curve inwards. Okay? And normally the plantar reflex is downgoing. Pathological is upgoing. That means there is extension at the metatarsophalangeal joint of the big toe and fanning out of the other toes as well. So in which case it's indicative of an upper motor neuron lesion. Sometimes it can be equivocal. You don't really know, is it a truly upgoing one or not? So in that case, you need to assess it, number one, in accordance with the other clinical findings. If there are other signs of an upper motor neuron lesion, then most probably this plantar reflex is also part of that complex. And you also compare with that of the other foot. Assuming the other side is normal, and you get the same reaction, in all probabilities it's normal as well. Okay? Okay, 5th years. Babinski reflex normal in children until what year of age?
1 year.
Okay. Yes.
2 years. They say all reflexes is normal under 2 years. I mean like generally lah, not that precisely.
But remember the Babinski one is the longest one. Okay. Right. Okay, we have finished the motor system for both the upper and lower extremities. Next, we go to the sensory sphere. So I believe you all have had a session on this already in CNE. What are the things that you want to assess in the... What are the modalities that you can assess in the sensory sphere? Seeing and temperature, some more?
Touch.
Touch, proprioception, and?
Vibration.
Two-swing discrimination, vibration also. So out of all of these, which one is the least discriminatory? The least precise? The least touch-na? Touch, actually, because you stimulate, if you don't do it carefully enough, you also stimulate the hair on the skin. So some I see they do start off with touch first, but in Malaysia they usually start off with the pain. And for that they'll use a toothpick, or sometimes you know the statistic. If there's no toothpick in the ward, they take the statistic and break it into two. Not bad. Okay.
Just break it, just break it.
Yeah. And then use this part. Now once, this one was before I revised the examination of the neurological system, and the registrar told me, okay, please assess the sensory sphere of this patient. Just took the, toothpick and then the registrar was just smiling, then she said, no. The first step, you take this and you have to touch it at the patient's sternum and ask the patient, what do you feel? It should feel sharp. If the patient feels that yes, truly rasa tajam, then only you proceed with the rest of the sensory examination, okay? Always touch it at the sternum first.
A variation is touching at the forehead here. Another variation. It can be here or here.
So, rasa tajam? Okay. So, then only you proceed. And at that time, I admit I did not study properly. I did not truly memorize the dermatome distributions of the archive cucuk only. Of course, that's not the way. That's why I said you need. That is also one of the things that mati you kena tahu, the dermatome distribution. So there are several guides. I hope all of you have the clinical examination of tallies. If not, there are many guides. Tip of the shoulder here is C5, C3 and C4 go above that. C6 will be the thumb and the finger. C7 is all this. C8 Thoracic 1 is this area here, over the elbow, on the forearm and the upper arm. Thoracic 2, the thoracic 4 segment corresponds to the nipples. Epigastrium, you also need to know the dermatome distribution over the abdomen as well. Okay? And then you test accordingly. 5, 7. By right, the patient should be properly exposed last. So you should be doing this on skin, but in this weather,